and welcome to my channel. As you all know, this is all about community medicine, making it easy, comprehensible by everyone who needs to know community medicine. Be it the student, be it the faculty. It's for all. Well, yes, I'm back after a hiatus due to various reasons. But now I am going to take you through the community medicine practicals, particularly focusing on the problem cards. Because of the CBME curriculum, the problem card, which used to be given earlier in the old regulation, has gone through certain changes. Earlier, the cards used to be handed out and you people, the students, needed to fill them out and write the answer in their scripts. But now it is a little different from the past, and now it is part of the Viva table. Of the 40 marks allotted to the Viva, 20 marks will be from the problem cards. It will be handed over a problem card, and whichever is picked up by you, you need to answer the relevant questions. So with that, let me tell you, today I am going to tell you the problem cards on anemia, leprosy, tuberculosis, some couple counseling cards, malaria, dog bite, night blindness, orbital spot. In fact, it can come in any of these forms, balanced diet, and immunization based diarrheal management. This is not an exhaustive list. There are a lot of other problems which may come, but this is a more or less comprehensive one. Besides the problem cards, you will also have the OSCE and OSCE stations where you will be needing to know everything about the ORS, how to prepare it, what are the precautions that you should take, the different types of ORS, and many more. Besides, you need to know very clearly about how to measure the mid-upper arm circumference, particularly with the circuit tape, the anatomical landmarks, and have a clarity about it. Know how to calculate your BMI, how to plot in a growth chart, identify models like measles, kwashiorkor, chickenpox, filariasis, sources of different vitamins like A, C, D. And apart from this, in the Grand Viva table, you'll also have the very infamously famous tray. And this tray will contain the different vaccines, the diluents, the contraceptives, the ice packs, and the mother and child protection card, and things like that. So this is a brief overview of how the practical is going to look like. But now, without losing any time, we will go into the problem cards. The first problem card that I'm going to relate to you is the anemia one. See what the card is reading. Go through it clearly. Find out the problems and then take your time and answer part by part. Here the question reads, a pregnant lady has come to you at 16 weeks of gestation. Her hemoglobin level is found to be 10 gram%. How will you manage the case? Two things to mark here. One is 16 weeks of gestation and the second is the hemoglobin level, that is 10. Now let us look at the anemia classification and let us focus on the pregnant women classification. In the pregnant women classification, normal is 11 gram per deciliter or more. Mild is 10 to 10.9 and moderate is 7 to 9.9 and severe is less than 7 gram. If you recall, the particular card reads 10 gram. That means the concerned pregnant woman is suffering from mild anemia. That is your provisional diagnosis. Now, when you have a case of pregnancy with anemia, then depending on the hemoglobin level, the management will differ. So whenever the hemoglobin is below 11 gram%, it is pregnancy with anemia. In case of mild anemia, one has to go for diet rich in iron, oral iron, vitamin C and deworming, and repeat the hemoglobin after 3 weeks, because that is the minimum period hemoglobin takes to normalize, increase its range. Then coming to moderate anemia is between 9.9 and 7. When it's less than 32 weeks, one can still continue with oral iron. When it's more than 32 weeks, parenteral iron is preferred because we have very less time for correction. In case of severe anemia, supposing it was given 6, that means then the status would have changed to pregnancy with severe anemia. If it is compensated and more than 36 weeks of gestation, one has to correct the hemoglobin to at least 7 gram% with Paxil volume before the labor, and then start parenteral iron according to the time available. But if it is less than 36 weeks, that is, we have little more time in hand, we have to correct the hemoglobin to at least 5 gram% with Paxil volume and then start the parenteral iron. In case of decompensated cases, we have to start the oxygen, correct the hemoglobin to 7 gram% with PCV under diuretic cover, and then start the parenteral iron. This is the algorithm that you need to know very clearly. Now coming to the management. Well, coming to the routine antenatal care, every woman is supposed to get 60 mg elemental iron and 500 microgram of folic acid daily for 6 months before delivery and 6 months after deliveries. And this is under the Anemia Mukt Bharat program. Now, it is for whether the woman concerned has anemia or do not have anemia. But in a case where the woman has diagnosed mild anemia, it is 60 mg elemental iron and 500 microgram of folic acid twice daily till hemoglobin level normalizes, and then one will get back to the prophylactic dose along with vitamin C, iron and folic acid rich diets in the form of the food items mentioned. This is the point when you may be asked, mention some vitamin C rich diet, iron rich food sources, folic acid rich food sources, and you need to go through them. Along with it, it is also important to get the treatment of hookworm, malaria, and provide health education and repeat the hemoglobin after 8 weeks. Provided your card read any hemoglobin level below 9.9, then along with all this, you have to mention that the woman concerned needs to be investigated for the cause of anemia. And in this concern, you may be asked that how many antenatal visits are mandatory, what is it advisable to come, what are the rates of improvement, and what are the parenteral therapy. The most common is the ferric carboxymaltose and iron sucrose. Even of the two, ferric carboxymaltose is the preferred one. And the improvement is generally evident within 3 weeks of the therapy. The hemoglobin % being expected to rise at a rate about 0.7 gram per 100 ml per week. Now from anemia, we move on to a different problem. The question card reads, a patient from Purulia district has come to a tertiary care hospital of Kolkata with a complaint of 7 hyperpigmented anesthetic patches on different parts of the body. On examination, both the ulnar nerves are found to be thickened. Diagnose and specify the management. Here, the two things that you have to note are the number of hyperpigmented anesthetic patches and the ulnar nerve thickening. So based on that, you will have to diagnose. Now, goes without saying this is a card of leprosy, but you have to justify on the basis of which you have made this diagnosis. Any leprosy diagnosis requires 3 cardinal signs being present. There is definite loss of sensation in a pale or hypopigmented or reddish skin patch, thickened or enlarged peripheral nerve with loss of sensation and or weakness of the muscles supplied by that nerve, and presence of acid-fused bacilli in a slit smear. In case of paucibacillary, the lesions vary between 1 to 5 and without demonstrated presence of bacilli in a skin smear. But in a multibacillary case, a case of leprosy with more than 5 skin lesions or with nerve involvement, that is the pure neuritic variety, or with the demonstrated presence of bacilli in a slit skin smear, irrespective of the number of skin lesions. So in this particular card, the provisional diagnosis is that of multibacillary leprosy. Why? The conditions sufficing for multibacillary leprosy over here are there are 7 hypopigmented anesthetic patches, that is more than 5. There is thickening of the ulnar nerves, and the patient hails from Purulia, which is one of the 2 leprosy endemic districts of West Bengal, while Bankura being the other. Now coming to the management. Earlier the standard immunity used to be followed, but we'll not go into it because now the current regime being followed is the uniform immunity, that is UMDT. Here for both paucibacillary and multibacillary, we have 3 drug regime. The only difference is in the duration. Paucibacillary leprosy has 6-month duration of treatment and multibacillary has 12-month long regime. And all these revisions from the earlier 2 drug and 3 drug to all being 3 drug is in order to avoid missing out on the multibacillary leprosy and no confusion with the blister marks at the operational grassroots level, causing more convenience. The 3 drugs that we mentioned are rifampicin 600 mg once a month, clofazimine 300 mg once a month, and then 50 mg daily, and dapsone 100 mg daily. Duration is 12 months. 12 blister packs of 28 days each. And the current adult regime for paucibacillary under UMDT, again the same drugs, but only 6 blister packs of 28 days each. So those patients of leprosy who have rifampicin resistance, there is the question of the second line drugs. And what are the second line drugs? They are the clarithromycin, minocycline or quinolone group of drugs like ofloxacin, levofloxacin, moxifloxacin plus clofazimine daily for 6 months. And this may be followed by clofazimine plus one of the second line drugs daily for an additional 18 months. Now coming from leprosy, we are into a couple counseling part. So this particular card reads, a couple has 2 living issues. The husband is 45-year-old and the wife is 38-year-old. They have come to you for a family planning advice. Which method will you advise them to adapt and why? And what are the standard guidelines to adapt this method? Well, since they already have 2 living issues, the advice that should be served to them is permanent sterilization. But do remember, we never dictate any decision. We can only facilitate and let them know the pros and cons of any contraceptive mechanism. It is for the couple to take the informed decision. The standard guidelines for suggesting permanent sterilization to any couple is only when the age of the husband is more than 25 and less than 50, age of the wife is more than 20 but less than 45, they must have 2 living children at the time of operation, And if 3 or more children, then the lower age limit may be relaxed at the discretion of the surgeon. And another thing, the acceptor must declare that there is consent of his or her spouse and has a clear understanding that the operation is irreversible and the other spouse has not been sterilized earlier. Now, from that, let us move on to another important problem card. Here you see the picture of a child's eye showing a pearly white spot on the bulbar conjunctiva. And the card reads, a child at the age of 11 months and 15 days has come with a bilateral triangular pearly white spots on the bulbar conjunctiva. Diagnose the case and how will you manage the case? Here the two things to note are, one is the age of the child, that is more than 11 months but less than a year. The description of the problem, that is bilateral, triangular, pearly white spot, the location on the bulbar conjunctiva. So goes without saying the diagnosis of X1b Bitot spot, which is in fact one of the most common indicator used for estimating the vitamin A deficiency in a community. It is said if the prevalence of Bitot spot among under 6 children is 0.5% or more, we consider vitamin A deficiency to be a public health problem in that community. The concerned program is that of National Vitamin A Prophylaxis Program, which you should be aware of. That involves prevention of vitamin A deficiency through promoting of consumption of vitamin A rich food, creating awareness, and of course prophylactic vitamin A dosage. If it is at 9 months, that is the first dose, it is 1 lakh international unit along with the measles and rubella vaccination. If it is more than that, it is 2 lakh international units. It is usually presumed at 16 to 18 months along with the pentavalent booster, and every 6 months till 5 years the 9 megadoses of vitamin A are given. This was what we talked about are the prophylactic doses. But when there is vitamin A deficiency as evident in this particular card in the form of Bitot spot, or there may be night blindness mentioned in the card, then we will go for the therapeutic doses. It is usually in case of Bitot spot 2 lakh international units of vitamin A orally, 2 doses at 24 hours interval and the third dose after 4 weeks interval. Mark here, since the child is aged 11 months and 15 days, beyond 11 months it is 2 lakh international unit. And any case of severe malnutrition is also to be given the 1 additional dose of vitamin A along with vitamin A rich food. Here you have to keep a track of some vitamin A rich food items. It is good to know the criteria for assessing the public health significance of xerophthalmia and vitamin A deficiency, and it is usually carried out among children less than 6 years old in the community. In case of night blindness, the minimum prevalence is taken as 1%, Bitot spot 0.5%, corneal xerosis or keratomalacia 0.01%, corneal scars 0.05%, and biochemical serum retinol less than 0.35 micromole per liter 5%. Now from that we move on to a case of dog bite. It's a very popular problem card, and the one in question reads, a patient has come to you with a dog bite at the left calf muscle. On examination there was abrasion with loud oozing of blood. What is the category of bite and how will you manage the case? Well, if you know the categorization, then you must be knowing that when there has been any exposure but the skin is intact, that is category 1. If there are minor scratches but no bleeding, it is category 2. If there is transdermal bite, that is the skin has been wounded and there has been multiple wounds, then it is category 3. And in that case, not only vaccine, but you will also need the immunoglobulin. So in case of post-exposure prophylaxis, we have to keep in mind the principles of treatment. Firstly, wound washing thoroughly with soap and detergent for at least 15 minutes. Passive immunization in the form of immunoglobulin and active immunization in the form of vaccines. In the questions of the active immunization, currently the government follows the intradermal regime. The other regime which is more common in the private sector is the intramuscular regime, which is also known as the SN regime. It's a 5-dose regime on days 0, 3, 7, 14 and 28. So the dose 1 is on the day 0. It is usually 1 ml and is given in the deltoid or in the anterior part of the thigh. If it is intradermal, it is much lesser dose, that is 0.1 ml. The Zarib regime is currently not practiced in our country. Rather, the official regime is this updated Thai Red Cross regime, which is intradermal administration for the post-exposure prophylaxis, and it involves 2-site regime of 0.1 ml at 2 sites at one time. That is, on day 0, you get 2 shots on the 2 sides, each of 0.1 ml. Here 0, 3, 7 and 28 days are the days of dosage. That is 2 doses, 2 doses, 2 doses. Then we miss on the 14th day and repeat again 2 doses on the 28th day. So it is called 2 plus 2 plus 2 plus 0 plus 2 intradermal regime. The intradermal regime cannot be given in immunocompromised or patients who are having chloroquine. So for rabies exposed patients who can document previous complete pre-exposure vaccination or complete post-exposure prophylaxis with CCEEV first dose delivered intramuscularly or a CBV delivered intradermally on days 0 and 3 is sufficient. Now coming from the dog bite, we come to a very important problem card. A patient had a complaint of low-grade fever, weight loss, anorexia, persistent cough for the last 1 month. On examination, sputum smear was positive for AAV. After starting treatment, he stopped medication for 2 consecutive months. How will you manage the case? What category of treatment will you allot to him? And describe the regime. So it goes without saying, this is of tuberculosis, pulmonary tuberculosis. And according to the new program of National Tuberculosis Elimination Program, that is NTEP, we have only 2 categories, the new one and the previously treated one. This particular treatment regime has to be by heart by each one of you. Now, apart from tuberculosis, another very important card is the present one. That is, a 20-year-old patient from rural Bengal has come to a fever clinic with the complaints of fever with chills and rigor for last 4 days. After examination of peripheral blood sphere, Plasmodium falciparum has been found. How will you manage this case? That is a card of falciparum malaria, but it may also be that of vivax malaria. You have to remember the 2 types of treatment. The card might read a particular state, which maybe from the northeastern states, and you have to follow the northeastern state regime, or it may be from the other state and then you have to follow the other state regime. In the other state regimes, what we follow is the ASSP regime, that is the artesunate sulfadoxine pyrimethamine regime. And each of the age group has a specific blister pack. In the 0 to 1 year age group, we have the pink blister. 1 to 4 we have the yellow blister, 5 to 8 we have the green blister packs, 9 to 14 red blister, and for 15 and all adults they have the white blister packs. So in case of northeastern states, the ACT-AL regime is practiced. Here ACT is the artemisinin based combination therapy and AL is the artemether-lumefantrine. You can see the dosage given according to the body weight of the person and the age concerned. You have to remember the basic things while you are saying in the Viva. You don't have time to write a lot of things, but you have to say on your own. So it is best to say in a comprehensive manner. So you better follow this chart and go through it. In case of malaria in pregnancy, provided it comes, then this is the algorithm you need to follow. In case of Vivax, the management is based on chloroquine, and until delivery, no primaquine, but weekly 300 mg chloroquine to be given. In case of falciparum malaria in pregnancy or mixed malaria, in the first trimester, if it so happens, quinine 10 mg per kg 3 times daily, plus clindamycin 10 mg per kg BD for 7 days. If it happens in the second and third trimester, then you have to follow the artemisinin combination therapy, depending on the stage it is coming from. Now, after malaria, we come to a very important practical problem, which not only in your problem card, we also see in your real life too. That is of vaccination. And one very important thing to note, each one of you should know the national immunization schedule by heart. It's not only given in the tray, it's asked in the grand viva, it is given in the problem card, it comes in all forms. This is not something you'd like to miss. Now let's come to the present card. A mother has come to you with her 10-month-old child. The baby has received 2 doses of pentavalent vaccine at 1.5 months and 2.5 months respectively. But the mother hasn't turned up for the 3rd dose on time. She is delayed and she's coming at the age of 10 months. So at present, what vaccines will you give to this child? Mention the dose, route and site of each vaccine as per the national immunization schedule. When will you advise the mother to come back for the next immunization? And what vaccines will you give in the visit? So this is the immunization schedule which you need to know by heart. That is, at birth, we have the BCG, OPV 0 dose and the hepatitis B birth dose. At 6 weeks of age, we have OPV 1, pentavalent 1, rotavirus vaccine 1, fractional dose of inactivated polio vaccine, that is FIPV 1, pneumococcal conjugate vaccine 1, that is PCV 1. At 10 weeks, we have OPV 2, pentavalent 2 and RVV 2. We do not have the fractional dose of inactivated polio vaccine or the pneumococcal conjugate vaccine. Again, at the age of 14 weeks, we have all the 5. There is OPV 3, pentavalent 3, FIPV 2, PCV 2 and RVV 3. At 9 to 12 months of age is the time for measles rubella. That is MR1 and JE1, that is the Japanese encephalitis vaccine and PCV booster dose. At 16 to 24 months, we have the MR2, JE2, DPT booster 1 and OPV booster. 5 to 6, we have the DPT booster 2 and 10 years, we have the tetanus and adult diphtheria, that is TD. 16 years, we have TD. And pregnant mother, we have either TD1, TD2 and TD booster. Things to remember in this concern is all the vaccines can be given in the same session but at different injection sites using separate sterile syringes and needles. It is absolutely safe and effective to give BCG, pentavalent, OPV and MR vaccine and vitamin A at the same time to a 9-month-old child who has never been vaccinated. And always remember, we are not going to start the schedule all over again even if the child is brought late for a dose. We'll pick up exactly from where the schedule was left off. Now coming to the IMNCI part. A mother has come with a child of 6.5 months of age weighing 7 kg with a complaint of loose watery stool for the last 2 days. On examination, it is found that the child has some dehydration. How will you manage this case? What additional medicine will you prescribe and why? And enumerate the regimen. Well, always remember in IMNCI, the basic things that you have to know is we assess. Based on our assessment, we classify. Based on our classification, we identify the treatment modality. So basically, we act. A for assess, C for classify, and T for treatment. In assess, what do? We look and we listen. So what do we ask? How long it has been? Is there any blood in the stool? We look at the young infant general condition, if the child is lethargic or unconscious, restless or irritable, if there is sunken eyes, how is the skin pinch, is it going back very slowly or is it fine? And based on that, classify the diarrhea. For dehydration, 2 of the following signs, this lethargic or unconscious or sunken eyes or skin pinch going back very slowly, it is marked as severe dehydration. And we have to give the first dose of antibiotics, urgently referred to the hospital while giving frequent sips of ORS on the way, and advise the mother to continue breastfeeding and keep the child warm. And if the child does not have low weight or any other severe classification, we'll have to give fluid for severe dehydration as per Plan C. If 2 of the following signs, it's restlessness, skin pinch going back just slowly, sunken eyes, we classify as some dehydration. So we advise in a similar way and follow up after 2 days. If there's not enough signs to classify as any of these, we mark it as no dehydration. So always remember the classification of dehydration is no dehydration, some dehydration and severe dehydration. So in case of no dehydration, we give fluids to treat diarrhea at home as per the Plan A. And we advise the mother when to return immediately after explaining the danger signs. Apart from this, there may be cases of diarrhea for 14 days or more, which is termed as severe persistent diarrhea. In that case, we also have to keep in mind that we have to treat and prevent the low blood sugar of the child while maintaining others. If there is blood in the stool, we term it as severe dysentery. And we also manage preliminary on the same lines and if necessary. So what do we ask? Let's recap. Does the child have diarrhea? How long has been the diarrhea? Is there blood in the stool? So once we have asked this, we look. What do we look? We look at the child's general condition, lethargic, unconscious, restless, irritable, sunken eyes. Then we offer the child fluid. Why? To find out if the child is able to drink, eager, very thirsty, and then pinch the skin of the abdomen. And based on these assessment, that the first act, the first A, we go on to the classification, that is the C. Classify the level of the child dehydration. And in case of no dehydration, we follow Plan A, that is treatment at the home and counseling the mother on that line along with zinc supplementation. And if there is some dehydration, we follow Plan B. We treat the child with ORS solution in zinc, breastfeed and reassess after some time. In case of severe dehydration, as mentioned, we follow the Plan C, provide fluids, if not by nasogastric tube, and refer the child to the hospital for IV fluids if the IV fluid administration is not possible in the given setting. always remember, when you are prescribing home-based care in Plan A, the fluid to be given has to be described elaborately to the mother, that breastfeeding has to be continued, given ORS or clean water in addition to the breast milk. Those food-based fluids like soup, rice water, yogurt drinks or ORS has to be given. And the mother has to be taught how to mix and give the ORS. So up to 2 years, 50 to 100 ml after each loose stool, and 2 years or more, 100 to 200 ml after each loose stool. And regarding the zinc supplement, the mother has to be told how many 20 milligram zinc tablets are to be given. Up to 6 months, you have to advise half tablet daily for 14 days. 6 months or more, 1 tablet daily for 14 days. And you have to show the mother how to give the zinc supplement. In case of infants, you have to dissolve the tablet in a small amount of expressed breast milk, ORS or clean water in a cup. In older children, the tablet can be chewed or dissolved in a small amount of clean water. And the feeding is to be continued. And whenever there is any danger sign like unconsciousness, convulsions, lethargy, inability to eat or drink, the mother has to immediately report back. And in case of Plan B, you have to give the recommended amounts of ORS over a 4-hour period. And the child's age-based calculation is only to be done if there is no means of knowing the weight of the child. Otherwise, weight-based treatment is preferred. So always remember, the home-based care has basic 4 rules: extra fluid, zinc supplementation, continued feeding, and knowing when to return once there is any danger signs. So now with that, IMCI based diarrheal management, a very interesting one and very relevant one also. How to frame a diet chart feasible for your CBME as a medical student. So let's presume that the medical student in question is a male sedentary worker, given the work pattern. So the calorie requirement will be 1 ACU, 1 adult consumption unit, and that is equivalent to 2110 kilocalorie. And in this 2010 kilocalories, the protein has to be according to the body weight. So presuming the body weight is 60 kilograms, it is 0.83 grams per kg body weight, which amounts to 49 grams in a 60 kilo body weight adult male student. And then we know that each gram of protein yields 4 kilocalorie energy. Then 49 grams will yield 196 kilocalorie. And regarding the fat, 20% should come from it. So 20% of 2110 is 422 kilocalorie. So if I divide it by 9, because each gram of fat yields 9 kilocalorie, it will show that we require 47 grams of fat every day. And of these, 50% should be from the visible fat, that is like, oil, vanaspati, ghee, dalda, those things, butter included, and rest from invisible fat, which are present in invisible form in the form of cereals and other vegetables. So regarding the visible fat, as we mentioned, 23.5 grams, let us presume it to be, approximately 25. So if a teaspoon holds 5 gram, then approximate requirement of visible fat in a day for you is 5 teaspoons. And rest carbohydrate is around 70% of it. The recommended daily allowance minimum for carbohydrate, even if you are dieting, it is 120 grams per day. The reason being, beyond this, brain metabolism is badly affected. Ideally, it should be 70 grams. So coming to the balanced diet for a male sedentary worker or a medical student having a sedentary work pattern. Cereal should be 270 grams. Pulse, if the person in concern is non-vegetarian, should be 60 grams. If vegetarian, should take additional 30 grams. Other vegetables 150 grams. Green leafy vegetables 150 grams. Roots and tubers 150 grams. Fresh fruit 30 grams. Milk 300 ml. Sugar and jaggery 20 grams. Fat and oil, as we all discussed little earlier only, 25 grams. Fruits 150 grams and nuts and seeds 30 grams. So with that, we discussed a lot of these problem cards. Now just a quick deco at some of the models. Again, it's not exhaustive. This particular one in question is that of measles rash. Why? Because it's generalized, maculopapular in nature, erythematous, confluent. It usually begins in the face and behind the ears and then spreads all over. That will be your clinch line that why you have said this is a measles rash. Now, another model popularly given is that of kwashiorkor, which is also known as edematous malnutrition because of its association with edema. So, it's a nutritional disorder most often seen in regions experiencing famine. It is due to the lack of protein in the diet. They have an extremely emaciated appearance in all body parts, but a pot belly. This particular model is that of food items which are sources of vitamin D like fish, sunlight, cod liver oil, egg yolk, butter, milk. You have to remember that vitamin D is fat soluble in nature. It is essential for utilizing calcium and phosphorus in the body and necessary for healthy bones and teeth. And its deficiency, it causes rickets, osteomalacia, poor dentition, bowel aches, etc. Now this particular model is the food items showing which are sources of vitamin A. That is green leafy vegetables, fish liver oil, egg, liver, butter, milk, yellow and orange vegetables. And again, this one is also a fat soluble vitamin. It is essential for proper functioning of the eye and necessary for growth and resistance to diseases. Its deficiency causes xerophthalmia as the ocular manifestation, and as extraocular manifestation, we have rough and dry skin in the form of rhinoderma and retarded growth and susceptibility to variety of diseases. Now here what do you see? These are the food items that are touted as sources of vitamin C. There's tomatoes, lemon, orange, papaya, green vegetables, grapes, carrots. And do remember, vitamin C is water soluble in nature. It is essential for the healthy bones and teeth, absorption of iron, necessary for growth and resistance to diseases. And the deficiency causes scurvy, hemorrhage, weak bones, teeth and gums. Thank you so much. Hope this helps you in your coming examination and gives you clarity. If you like the video, please do subscribe to my channel. It means a lot. And give a big thumbs up and press the bell icon just beside the subscription button. And keep tuned in for more academic contents. Thanks once again.